Well, it's an honor and a privilege to be here today. I recognize a lot of familiar faces here. Thank you all for coming. I know some of you I've met at other meetings around the country. And so it's a core group of people. It's fun to see this thing snowball over the last 12 years. These movements and the Ocular Melanoma Foundation are really important, and really appreciate your participation, guys. So we're going to talk about treatment today, and I know that some questions have come up, and let's just see a show of hands. How many people have had your eye treated for melanoma in the room here? You, that's 20, 30 people, at least 40 maybe. So I'll bet most of you, how many of you guys have had radiation to your eye? That's maybe the most of you. And how about enucleation? Okay, fewer number, so that's the trends these days. At any rate, let's just go through these slides. Again, welcome. I do believe advocacy makes a difference. I've been lucky enough to be on one of the committees that reviews the research proposals that come in from all over the world. And we read through these things, and every one of them looks like a Nobel laureate thesis, and we have to pick the very best ones, and I'm confident the money you raise is going to the best researchers in the world, so, I can vouch for that. And also, it improves communication. You guys have a rare disorder. Communication, as we've heard earlier, very difficult to discover about what it is you have and how to approach it. So you have a rare disease. As we say in Colorado, if you're hearing footsteps, it's most likely horses. You don't think of zebras, right? You guys are zebras. You have a really rare and unusual condition. So I like to use that as just kind of an imagery as we go through this. It's about 2,000 new cases a year in the United States. 7,000 in the world, apparently, has been estimated. And this is what we call an orphan disease, in a way that if it's less than 4,000 cases per year in the United States, you don't have a big movement. It's not like breast cancer or other forms of cancer. We've gone over a bit of the incidence and frequency, and the cause still remains unknown. We don't know. It's been very frustrating. There's been some tantalizing information genetic mutations that have been discovered, but they haven't been exploited yet in terms of how to use that information for a treatment or a cure. But that appears to be a promising avenue. Just to review a few basics, the melanoma can occur, it occurs in the wall of the eye. The eyeball's hollow, so all the tissues are in the wall, and this is the focusing mechanism. So the melanoma could be in the iris or the ciliary body or what's called the choroid. And most of them are in the choroid, but you all will begin to be different kinds of zebras if you think about it, because some of you have one and some of you have another. And it can be important in terms of the way we think about it. Melanoma starts in the eye. This is what makes it unique. It's really one of the only cancers that starts in the eye. And it does have a potential to spread in the body. Just so you know, there are a lot of other cancers that can go to the eye as well. So you may have heard someone else with eye cancer, and probably not melanoma. So a new patient, we heard a story today, a great story, very poignant, thank you. This is what happens, a routine eye exam, or occasionally a patient has symptoms, see an eye doctor, usually an optometrist, go to a specialist. Oftentimes I'm like the third or fourth doctor the patient's seen in a very short period of time. And we have to work on diagnosis. That's the hard part there. That's really bad. Then once we've diagnosed melanoma, we have to say, is it in your body? And now we have to think about your body. It gets very complicated really quickly. Treat the eye one way or another. And then we wait and see how the eye responds to the treatment. As the treating eye doctors, we're responsible for the care of the eye. Dr. Oliver and I will be talking about that. But one question is, how do we know it's melanoma? And the accuracy of diagnosis is pretty good. This is very good. We think with the COMS, I forgot if you showed, 99% accuracy typically, if it looks like a normal melanoma. There can be weird variants though as well. So we have to look at it. Sometimes it's only after a period of observation you realize, oh, that thing's a melanoma. There are a lot of benign things that can grow in the eye. We need to sort out the benign things from the bad things. But once you've been diagnosed and even treated, we use the same methods to follow your course. I just want to go through some of the images. You've all had color images. There are angiography techniques to look at the blood flow in the eye. Put tracers in. Here's a tumor, and underneath the retina you can see. Ultrasound is used to measure the tumor. There's various kinds of ultrasounds. That's going to give us a three-dimensional calculation. How big is this thing? Is it getting smaller? You guys have all been through this, right? But initially, for our diagnosis as well as follow-up, we'll do these techniques. There's a really neat innovation in laser scanning instruments that make the most fine measurements inside the eye. And there's different modalities that will penetrate different tissue layers. And autofluorescence is one thing you might see. It's this amazing scanner. We're looking for leaking, and I think you can appreciate here, the tumor is kind of hard to see on the color photo. But with the autofluorescence, we get this beautiful high-resolution black and white image. This is the same eye. And so this amazing new technology really helps us evaluate things. Are things changing, yes or no? We can answer those questions. On the other end of the visible wave spectrum, infrared, we can, again, here's the same eye, and just you can all appreciate how much better we can see that. We have the ability to use a scanner to measure the thinner and smaller ones in 3 dimensions. And this kind of just shows you that with the high resolution here. This tumor here is probably about 1 millimeter thick, so a really small one. So this is what you do when you go through all those darn tests before you see the doctor, right? This is what we're thinking. Is this thing getting better? Is it getting worse? What's happening? Biopsies. How many of you guys had biopsies? And how many of you didn't have biopsies? Yeah. So biopsies have been emerging in the last decade, and not everyone gets them, not everyone wants them, but it's available. And most people, we believe, should at least have that discussion or have access to it. And it's not required by any means, but it provides more information. And I think Dr. Oliver is going to go into that a little bit more. But that's part of really the treatment plan, we need to discuss, should we biopsy or not? The biopsy is not to confirm the diagnosis so much as to get genetic material, which can be used later to evaluate predictively, which way are we going, what do we need to think about? So basically risks, there are certain higher risk characteristics and lower risk characteristics. We know there's some people that get melanoma of the eye that are never going to get it in their body. And what our effort as clinicians has been trying to figure out who's more at risk of getting it. And then what can we do for them? What extra things do we need to do? So just in general, size is one major factor. The larger tends to be a higher risk when we look at large numbers of patients. Genetics, you may have heard of class 2, class 1. There's other names for these things, but basically there are a variety of tests that will separate you out into a higher risk genetics or a lower risk. Finally, the location of the tumor in the eye. It could be in the ciliary body, higher risk overall. And that's been known before all the genetics. The iris is thought to be a very low risk place to have a melanoma. All right, I'd like to go over a little bit. We're talking about patients here. You guys have all been through this. Phase 1, diagnosis. I call it shock and awe. No one likes it. It's horrible. You weren't expecting it. You didn't know it. Why? You lose control over your life. You have to do certain things. You have to get integrated into the whole big medical system. And you don't know where you're going for a while. And all you know is you need to be treated pretty quickly with something that could blind you. So it's a really terrible situation. You guys know this. But I think you also discover more about yourself, and hopefully organizations like the OMF can help you orient a little bit. Am I in a high-risk group? Am I in a low-risk group? How do I know? What are the issues I need to be tracking? And one thing I want to say is in a meeting like this, you're all different from each other. It's neat that I think it's great you get together and share experiences, but you don't all quite have the same variant of the disease. And that's what really introduces a level of complexity as you're interacting with each other. You understand that you're not sharing the exact same experience. It's a challenge. Medical team has a challenge. We're trying to do what's the best thing for you. What is the best thing? Well, first of all, we want to eliminate the cancer locally in your eye, and then address the systemic risk issues. And if it's there systemically, we would love to be able to get rid of that too. We want to preserve vision. That's second on our list here, guys. We, unfortunately, as an ophthalmologist, I've blinded many, many people doing the radiation treatments or removing their eyes. And that's, my fellow partners just, they don't like that at all. As ophthalmologists, we hate the idea of that. But nevertheless, we have to be willing to sacrifice it. But we don't have to give it up unnecessarily, and there's ways to try and preserve it as well. I think it's important to preserve the eye, too, if you can. Cosmetically, cosmetics are an important part of it, of patient care. So we think of, basically, patients get to choose what happens to their body. Last I checked, I think that's still true. But the healthcare workers, our duty is to inform you and then help guide you through the thought process and guide you through your treatments. We usually think of three principles. One, life is the most important. If there's something life-threatening, we've just got to take care of it. Vision, very important. I mean, vision is one of the highest, most valued bodily functions that people have, even as they get very old. Vision is one of the most important things. We don't want to give that up if we don't have to. Quality of life is really important. How about your pain? Is this a painful condition? Do you have anxiety? You worry about your appearances? These are all important issues. These all come into, I'm calling treatment, in a way. We have to think of all these issues as we help you think through what's the best choice. Well, I'm going to get to the nuts and bolts of it right now and just talk about how we get rid of the tumor in your eye or how we attack it. And I like to think of it as a toolbox. We've got a bunch of different treatments. We do radiation, we do lasers, we can remove your eye if we have to. And these can be used in various combinations. Usually you start off with a major treatment, either remove the eye or do the radiation, but these other tools can also be used with you. And the recommendation specifics are going to depend on what's unique about your condition, where is it located. And so it's hard to generalize. When we get to treatment, most patients, they kind of have a determination. They say, okay, I figured it out, let's do this. Well, I think all of you guys have been through that. Is there anyone here who has not been treated? Okay. Okay, well, okay, I'm sorry. I hope this is helpful for you. Okay, good. But psychologically, I see a change in the patients. They got their feet on the ground, they're ready to march through the treatment, take care of it. So when we look at these treatments, the standard treatments are still, right now, radiation. Now has anyone had proton beam therapy here? Okay, yeah, of course you were back in New England over there. Was that in New England or Boston? Were you in Boston too, sir? San Francisco, a couple places, but in most of the places in the country, people will do what we call brachytherapy. I don't like that word, I don't know what it means, but it's what we do. It's the plaque treatment. We'll go into that in a little bit more detail. There's also laser treatments. Has anyone had just laser treatment for their eye here? Right, sir, did you have TTT, do you know, diode or PDT? I see, good, yeah. So the laser treatments are still, good for smaller tumors, depends on the location, and we'll go into that a little bit. And then finally, removing the eye. Just gets rid of the eye, gets rid of the tumor, in most cases, locally. Radiation treatment, brachytherapy, most common. We use it for medium-sized, mostly, tumors, as defined by the COMS studies. And there's been a number of papers out there showing that it can be as high as 98% successful in treating the tumor if it's done right. So we usually have a very high degree of confidence we're going to take care of that tumor in your eye, but we're also watching for that 2% failure rate. And that could happen over a period of years, that 2% might emerge. Basically, we use the I-125 radiation, and it's applied to the tumor, and this is a schematic showing the tumor in the eye, the plaque on the outside wall of the eye, and then these are the radiation doses that fall off. Why is that important? Well, we'll come to that in a minute, but it can damage some of the structures depending on where it's located. But basically, as you know, there's two surgeries. We put it in and we take it out. 3 days later, 5 days later. It kind of depends on where you are and who the radiation team is, the oncology team you're working with. Before surgery, a lot of anxiety, certainly. Still a lot of unknowns, and worry about loss of vision. But pain is usually not an issue. I hope I'm right. Does anyone disagree with me? How many of you disagree with me? There's a few. Okay. So it's rough getting through there. It can be, especially if it's in the front of the eye. There's no doubt. So it's the stitches, darn it. Well, here is another picture of a plaque. And again, another diagram of the radiation dose that falls off. But it's designed to treat the tumor all the way up to its very tip, typically is what they aim for.
How do you get back?
If I told you, everyone would know how to do it. We can't do that. Actually, that's a good question, and here's a picture. In fact, I think some of these fingers are mine and some of them are my dad's. This photo was taken a while ago, but I literally followed in your footsteps today, right up here, and in the operating room. But that showed the ultrasound. I think we have another picture. We use the ultrasound in the operating room. Here's Dr. Reiner, our radiation oncologist here, checking the numbers, checking the math. The day of the surgery, this patient's just had a surgery, and we're just making sure everything looks good. So that's why they're in the OR. That's what they do. But this is slipped around behind the eye. Actually, I'm sorry, I took the slide out that showed how we do it. But the long and short of it is there's 4 muscles, and we can slide it between the muscles or take one off and slide it around the white eyeball. And there's space back there, and we can get it wherever we need to. Sorry? We don't pull the eye out. What's interesting is, and there's something mysterious about the eye. It rolls back and forth, right? My daughter, she rolls her eyes at us all the time. Up, down, but there's no axis. So how does it turn? I've never really figured that out. How does it stay where it is? But there's muscles that will turn it up and down. And so we just will turn the eye around in its socket, leaving it right in place. And there's a space to slide it around. But I get that question all the time. Can't I just leave my eyeball here and pick it up when you're done? Problem is with radiation is it has complications, and Dr. Oliver's going to speak about that a little bit more, but basically there's a blast zone that comes out of where the tumor is, and it could cause damage typically to blood vessels, and that's the first thing most people run into. It could be a couple years down the road where their vision starts to become a problem. I want to touch on laser treatments. There's actually several different kinds of lasers that we will use. And the one that I think we were talking about earlier was this TTT or diode laser. Like the traditional argon laser, these burn the tissue. And so it's a thermal injury, and it can work quite well. In fact, people tend to think there's about a 1 out of 6 failure rate. So it's not as high as maybe the 98% we see with radiation. And yet, if you walked into Vegas, you'll have a very good weekend if those are your odds. So there's another one that can be used where we put a dye in your vein and then it's a light activated dye. Some of you may have had that. Anyone had PDT around here? Okay, so it's not first line therapy by any means, but it can play a role at times. Enucleation, sometimes that's it. We just got to do it. If the tumor's too big at the very beginning, that's going to be your choice. The eye may become painful after the radiation, or it might just slowly wind down and eventually might be enucleated. And, there's a psychology to it. But again, most people that are enucleated feel pretty good about it afterwards, actually, I think. People here that have had their eyes enucleated, who were those folks? How recently was that done? 7 years ago. Am I totally off base here in saying you've gotten used to it or you got used to it? It's not a problem. It wasn't a problem.
Same page, fully agree, not a problem at all.
So there is a debate a bit, and should we go through all the radiation and drag you guys through all that long course, or should we just say, get the eye out? Here's actually a picture of that procedure showing, we make an incision. Here are the muscles that we were talking about earlier, up, down, side, side. And the eye is taken out, and then an implant is put in, and the muscles are reattached to it. And then you have a skin covering that looks like the inside of your mouth, a mucosal membrane. And then you can get an artificial prosthesis. And of course, this is a pretty neat appearance here that we see. So it can be pretty good, actually. And so sometimes that's the right choice. You may have to go there. Phase 3 is what I call after you've been treated. Then you're recovering, trying to get back to work, kind of get your normalcy back, but also adjusting to the new situation you're in. And you might need ongoing treatments to your eye as you're recovering. Sometimes we have to go back to the operating room for a variety of things. I just briefly want to touch on that. Of course, you would have your enucleation or your radiation treatments there, but there's vitrectomy might be used for your biopsy. There's a cryotherapy can be used to freeze the treatment, laser destroying tissue. And vitrectomy is a way we can go inside the eye. Are people being nauseated by this? Are we okay? It's kind of neat. I don't know if anyone's had like the arthroscopic surgery. It's neat these days we have small incisions, really tiny ones. And we can get in with a light and a cutting instrument and clean out the eye. And sometimes that's needed at some points. So eye surgery is pretty advanced and it can take care of some of the problems that can occur. Cryotherapy we can also sometimes use to freeze through the wall of the eye to destroy a small tumor. All this, though, I have to say, to me, still seems pretty primitive. We're destroying the tumor and trying not to destroy the eye. And are there better ways to do this? So there are some research and multiple projects going on, in fact, and Dr. Oliver may tell you about his work to try and reduce radiation side effects. Very interesting. There was a trial that we were participating in looking at taking a virus, actually a piece of a human papilloma virus, and they attach a toxin to it. We inject it in the eye, and then we shoot a laser at it, and it's supposed to melt the tumor away. That's not standard of care. It's all experimental right now. But it's being done. People are trying these things. Injections of therapeutics, looking at biological agents. Something called tissue factor has been found to be expressed at high levels on the tumor surface. And there's antibodies now that are safe to use. And we've just participated in a project looking to see if that helps. So there's interesting research. It's great to see it, that there's great new ideas coming out and even making it into the clinics. Getting near the end here, the phases of patient experience, kind of the last phase is once the dust has settled on your eye, still worry about what do we need to do. Do we still need to take pictures, images, body images? Sometimes genetic information will inform you. If you have been genetically identified as being in a high-risk group, there's a variety of studies going on around the country that you might participate in to try and prevent cancer from developing later. So ocular melanoma is a chronic condition, and you're going to need a lot of follow-up no matter what you have, and no matter which brand of it you have. And as we said earlier, teamwork's needed, obviously, and this is one of the great aspect of your team here today. And hopefully you'll be able to find camaraderie here today, work together, support each other, and together maybe get a stampede going, okay, guys? So anyways, appreciate your time. I look forward to answering questions either now or we have time. We have time for a couple questions, maybe? All right, are there questions?
We can do some questions now, or we can do some after Dr. Oliver's too. If you have a question now, we can run the link.
Thanks. Dr. Hovland, I'm going through a clinical trial for radiation damage to the eye. That's Avastin by Genentech. And the results, if I've been able to worm out of my retina specialist, hadn't really improved many people's vision, but a lot of the people in the studies, their vision hadn't gotten worse. In others, it may have stabilized it. Has that been your experience?
Oh yeah, definitely. Definitely. The correct answer when you're in medical school, you learn about your third year or fourth, but certainly by your fourth year, that when you're ever asked a question, the correct answer is, you have to start off with 2 words. It depends. And it does depend on your situation, and it's hard to generalize, but in general, and I think Dr. Oliver is probably going to go into this more, but those types of therapies have been very useful in my experience, and it can help a lot of people. It doesn't help everyone. On a note on research, you may be asked to participate in research, or you might be considering participating, and I think my father said it earlier, the practitioners usually have a feeling of what we call equanimity. We don't know which one's going to work. We hope which treatment which way is the right way to go. We hope one works. And as a patient participating, you won't know that either. You're going to be randomized into one or the other, perhaps. And that's the way science is done, comparison of populations that are treated. I always like to, when I'm talking to my patients about it, though, I always like to put the little asterisk and say, individual results may vary, though. So, we don't know. As doctors, we say, 10%, 12%, these are different. But as a patient, it doesn't look that way to you. And the statistics don't matter to you because your course is unique. So when you're in a research, it's hard to know sometimes, is this working or is this not working? And I think the more I do these things, I realize that the patients that participate in research are really like the soldiers in the army. And you say, I'm signing up and I'm doing this and it's going to help. Maybe not me, but it's going to help the general cause. And so for all of you that are participating, it's very important. For those of you that can't or don't want to, that's fine. But research is you have to have a different mindset when you go into it. And I would say good research oftentimes is done where the doctor doesn't know what he or she is doing or what the outcome is even. It's called masked studies. And so oftentimes we rely on that central committee that's looking at all the data to give us the answer. And that can be years in the waiting. It can be hard.
As a direct follow-up to that, because I'm going through Avastin as well, and I'm now 5 years out, 5 years and a month. How long do these injections go on? Like, how long are we going to be getting these?
Well, there's research going on on improved delivery systems. I'll let Dr. Oliver may go into that a little bit. But, as you know, people with macular degeneration or diabetes are getting the same darn injections monthly or every 6 weeks or sometimes less frequently. Well, when I get that question a lot at the clinic, and I say to my patients, well, today this is the right choice for you. We don't know, but I've had patients, I've personally given over 50 injections, or I don't even want to count, maybe 70 or 100 even on some of these patients. Those are macular degeneration patients, but I don't think there's a limit. It's a very tiny needle, and you're going through the side wall of the eye, which is basically a piece of soft leather. It doesn't appear to be any damage to the eye after repeated injections. So, yeah. Uh-oh.
Every 4 weeks again.
Yeah. Well, just so you know, and I don't want to take up too much of time here, but one of the things we do in a general retina practice, one of the really cool ideas that's coming out, it's interesting how fields can affect each other. The development in one field can help another field. And what we're looking at is these implantable, I call them test tubes. They're very tiny, and we make a little incision in the eye, implant them just right in a special spot. And they have a little cork that leaks slowly. And these patients now, we were expecting to do monthly injections. We put one of these in their eye, and some of them haven't needed a treatment in well over a year. So I think the long-term delivery is the way to go. Some people have looked at long-term sustained delivery of steroids, for example. We're doing some of that in our clinic. And so for now, probably the best way to go. But the idea is to stay in the game, preserve your retina the best you can, so that when the improved technology comes along, you'll be ready for that.
Any other questions?
Okay, good.
A pre-question maybe, do you gather tumor tissue from some people?
Well, We don't store it ourselves as a warehouse or a
Yeah,
deposit.
but you do that as part of your treatment of the eye.
For the biopsy, during the treatment, we will usually obtain a biopsy.
So here's my question finally.
Yeah.
Are you doing a fine needle aspiration or are you doing vitrectomy at that stage?
Fine needle aspiration.
Okay. Always.
Yeah.
Okay.
I just have one quick question. So in removing the eye, even if it's a small tumor, can you not ever have to do follow-up? I mean, if you remove the eye?
Well, it depends.
I was going to talk to her.
Chat with one of us after.
Yeah.
Yeah, I
okay.
mean, like I say,
Because I don't want to deal with this anymore after this. I'll get rid of my eye if I have to.
I encourage you to ask that question to everyone you meet today. Honestly, I think sharing notes is a great way to go. Well,
Okay. Well, I don't want to react.
no, I think I had a guy drive from Ohio or from someplace, Missouri, come over here, and I met him, and he said, "You're removing my eye tomorrow." And I said, "What are you talking about?" He said, "I just diagnosed you." And he said, "I called all around the country, and you're the only guy available to take my eye out tomorrow." And I did, and he was happy. But if the eye's removed, then the tissue's evaluated later for high risk or low risk. There's a risk assessment done on the eye after it's removed. And if it's a high risk, it still doesn't mean that you don't have to worry about the eventual discovery of the tumor later in your body. And that's the hard part, everyone. I'm not going into that really too much here, but the idea is the tumor, the class 2 or the high risk genetics tumor, Dr. Harbour, who invented the test, he called it the breakout gene, meaning the cells have already figured out how to get out of your eye. They're already out, probably. But the question is, what happens then? What happens to them? Well, I like to think of them as like Velcro balls, and they stick to the Velcro on your liver. But they don't cause cancer for a while, maybe, or maybe not ever, if the immune system's attacking them. So there's really complex biological models. And the idea is, if you're a high-risk patient, and we know they're probably already stuck to your liver, maybe you can get them with a chemotherapy or some other agent during that time period where they're clinically undetectable, but after your eye's been treated. So there's still a lot of questions. I'm sorry, I can't just answer your question on the fly here. Yeah.
From my experience, when an eye is removed, it's typically a same-day procedure. So the patient goes in, comes out the same day, and is sent home. And then other patients who are treated, like my wife was treated with plaque, and then she lost her vision slowly. But I noticed that with both patients, there was no occupational therapy that helped these patients to learn how to function either with diminishing vision or with the lack of vision in that one eye. And so that patient is sent home. There's no physical therapy, there's no occupational therapy, there's no psychological therapy to help them emotionally to adapt. Is there any consideration to adding that to the treatment for these patients, whether it be enucleation or any other treatment? So then as they are having to adjust to this new life, they're given the tools, whether it be just driving, going to work, doing laundry, basic functions that they're left to do on their own.
That's a great question, and that's clearly an exposed weakness. Absolutely. Yeah, no, we don't do a good enough job there. There's no question about it, and you guys can see it because you've been down the road, and we're maybe blind to it because we're doing what we're doing. But there are people called low vision specialists, and these are generally optometrists who have dedicated their practices to working with people who have real challenges to their vision. So I would ask your ophthalmologist, is there a low vision specialty clinic in somewhere that I can go to be evaluated? And they make recommendations. At the university, Dr. Kara Hansen's fantastic. And she even got into a car with one of my patients and drove around with him. What kind of doctor is going to do that? That's these low vision guys. So, but the referral to that, the counseling, I'm sorry, there's a gap. There's no question about it.